Thank you, Devin, for including me into the program. And Devin had asked me to be more practical rather than theory, so I'll try to be as practical as possible. The visual fields, is basically what we do is we are mapping the retinal sensitivity of the retina because we have photoreceptors and the signal is carried by nerve fibers to the disc to the brain. So which part is, the retinal parts, they are not equally sensitive, so that we know from the normal database. And the predetermined points are picked in a way to give you the maximum probability of detecting if there's an abnormality in the retinal sensitivity. There are a number of strategies and algorithms to get the visual fields quickly and reliably. There are a number of machines actually used for this. I have no proprietary, I have no commercial interest in any of these, but predominantly you use Humphrey and Octopus. These are the most important, frequently used ones, but there are others also. Typically, we have to choose what we kind of an algorithm that we want to use for detecting the visual fields, and typically we use either a 30-2 full threshold or a 30-2 CETA standard. That is a proprietary algorithm which goes into most of the Humphrey fields. You could also use a 24-2 CETA fast, and if the visual field, if the glaucoma is advanced, then you probably have to use a 10-2 or macula because there's not enough sensitive retina around. Any of these tests can be used, but most of the glaucoma surgeon would prefer 24-2 CETA standard because that is fast enough and that also gives you a good information. But if you want to be more thorough, you go for 30-2 full threshold, and if the patient is not able to do it, it can't sit for a longer time, the perimeter, you probably have to choose CETA fast, which is fast but is not as robust as other two. But 24-2 is actually a very good compromise between all these strategies. Now, how we analyze the visual fields, you have to go in a systematic manner. Most important thing is that you make sure that the patient, you are talking to the same patient, that you have visual fields. So confirm the ID of the patient. To find out whether the patient was done reliably or not, have a look at the test parameters. Most of the parameters would be standard, but there are few, they would vary from patient to patient, and that could affect the visual field, like pupillary size or visual acuity, those things. And other are mostly kept, constant. And then once you are satisfied on these counts, then you go to interpretation of the data. Now, these are the two visual fields I'm showing you. Can we have the front lights off? No. What we have is that this is 24-2 and this is CETA fast algorithm, again 24-2. The only difference in two is there's a good young patient and he's a good performer. So both of these tests kind of look like same. This has taken about 4 minutes to do, and this has taken about 3 minutes to do. So CETA fast is quite quick. But if you have a patient who cannot do a 24-2, then probably CETA fast is good enough. But otherwise, this would be more reliable. So when you're looking, when you go about examining visual fields, look at the identification of patient which goes somewhere here. And parameters on this side, these are the fixation losses, false positives, false negatives. So these are the reliability parameters. So anytime patient is not reliable, these parameters will be kind of the perimeter will flag them. So you will see a X sign or 1 or 2 X or crosses in front of those parameters, and then you'll know that this is not reliable. And also you'll get some percentage of losses. So anytime your percentage goes like 15-20% in that range, then you start suspecting the visual field may not be good. But if it's less than 10%, it's kind of a reliable field in general terms. Now, these are the test parameters which basically says the visual acuity, the pupillary size, age of the patient, date of an examination. So all these, and also the refractive errors. So if there's a presbyopic age patient, and make sure that you have given some refractive correction there, which will be indicated in this. Then you look at the next part, you look at the data, the actual perimetry data. Now, this grayscale basically gives you an overall visual impression, and this is useful in the sense that it draws your attention to certain points in the visual field which you have to look more carefully. And in this field, it doesn't show much, and if you look at these values, can you focus this a little bit better? This is a bit out of focus. Can you focus the projector a bit? So it gives you the foveal sensitivity, which is somewhere around 34, 35 decibels. And around that point, you will see that in the parafoveal area, it should go a little bit down between 30, 32, and gradually it goes off. But, there's no sudden there's no points which are suddenly depressed, and they're all kind of uniformly distributed. That's kind of a normal pattern for a visual field. So that's the important data that we look into when we are looking at the visual fields. And then you have the next graph. This is called the mean deviation plot. Now, what Perimeter does is Perimeter compares these values with the built-in database. And if there's a change, if the values are low, they will be flagged here, and they'll be shown here. And also, and then the software actually looks at whether if there's any generalized reduction. Suppose there's a cataract or refractive error, so that would reflect in the general overall reduction in the visual fields, and that factor would be computed and taken off from the calculations, and then what you call a pattern standard deviation that will be plotted. So from glaucoma point of view, you must look at these values, and also the PSD is quite useful. And then Perimeter will compare the upper hemifield and the lower field, and if there are different 5 areas in the upper and lower, and if they because the theory here is that because the glaucoma field loss is not symmetrical over superior and inferior hemispheres, so if there's any differences in the sensitivity, that will reflect in the GST, that's glaucoma hemifield test, and this will be the normal or reduced sensitivity, or it could be abnormal or borderline. And then you have a visual field index, which is compounded according to these. So each point tested is given a value, and the central points have more value than the peripheral ones, and in the end you have a score. Ideally, it should be 100%, and like in this field, there are a few points which are missing, and so the score is about 97%, so it's not 100%, but that's normal. There's no one cutoff value for this score to say this is glaucomatous, because it also is kind of also reflected by the overall reduction in sensitivity. But higher the score would mean the better visual field.
Sir, very often in practice, we've seen, sir, if you could go back to the previous one, the two non-edge points, previous slide, sir. Both are showing non-edge points, and in practice, I've seen that treatment is started for such a field. So would you agree with that?
No, I think you have to look at the visual field only tells you that there are points of low sensitivity. Now, whether they fit into a glaucoma pattern, that you look into it, then you have to look into what the analysis is, the software analysis is, but most importantly, you have to go back to the patient
Absolutely.
and see whether it corresponds with what you're seeing in the patient. So I'll come to that again in my remaining slides. So this is how, I think this is another patient. You have a reliable indices, you have the parameters which are kind of known, and grayscale shows obvious defect here, and if you look at the values here, all these values are markedly depressed, and not only in this quadrant but also spilling over to this quadrant and this quadrant. So it suggests that there is a visual field defect here, and whether this visual field defect is also then kind of on the total deviation plot and also the pattern deviation plot. The GST is abnormal, and these the mean deviation PSD, they're all flagged at a significance level. So these notations are basically the significance level. It suggests you the probability that what is the probability that this point is significantly depressed or it's not depressed. So this gives you a kind of visual field defect, but then you have to see whether this is glaucomatous or not. So you must always go back to the patient and look at the disc. So you can see that there's a disc which shows a glaucomatous change in inferior notch. There's a nerve fiber layer defect, and so this matches. So now here you can comfortably say that you are dealing with a glaucoma patient. Now this is another patient. This is glaucoma or not? Now you're seeing this visual field here. You can see the reliable fields, the test parameters within usual range, and you can see that there are some values. At least one value is depressed to 0, and that is also shown in a grayscale, like a nasal step. But if you go to the PSD is more useful here, and you can see there are more missing points in this quadrant, especially below the horizontal line, and also these indices are flagged as abnormal. So again, you have a visual field defect, and again, you always confirm it whether you have glaucoma or not. And if you look at the the disc here, you can see there's a small notch here. There's a visual field defect, nerve fiber layer defect here, and this corresponds with this nasal step. So again, it makes sense. So what you are seeing in the visual field is actually also seen in the fundus picture. So you make a diagnosis of glaucoma. Now this is another. What do you think about this visual field? Now let me ask you. Now, this is a reliable field. All the parameters are good, and you can see there is all these values are good except one or 2 points. Now, there's a 1 point missing here on the PSD shows that the total deviation is not showing anything, but the pattern standard deviation is showing actually point, which is reduced to less than 1%. So this is kind of what is the Anderson's criteria. So this fulfills the Anderson's criteria, this point. So you have a point, and there are 2 adjacent points which are reduced sensitivity. But all other parameters are normal. The government, this is the GF, the glaucoma hemifield is borderline, and these parameters are actually within normal. So is it glaucoma or not? Now, many times you may tend to ignore these points, but again, go back to the patient. So let's see what this patient has. Now, you have a little, thinning of the nerve fibulae here, and if you look more carefully, there's a nerve fibular defect, very subtle, and also there's a nerve fibular defect here. So if you look at this picture, now this seemingly very isolated point, depressed point in the visual field becomes significant. Now, if this was not there, then you probably ignore and just repeat this field. You are going to repeat this field anyway, but in view of this finding, even this becomes a significant visual field defect. So that's how you basically correlate visual fields with your disc pictures. Similarly, in another patient, with the time is running short, so I'll quickly gloss over. Again, another patient who has some visual field defect, mostly in the inferior, and you correlate with the optic disc. You have a notch there, you have a nerve fibular defect, and that goes with the inferior visual fields. Now, again, this is a patient, a reliable patient in all these, but you can see there are a lot of grayscale shows of dark areas, and these values are depressed, and also GST is outside normal limits, VFI is low, and also these indices are actually out of range. So it would suggest, the analysis would suggest that this is a glaucomatous visual field. But something is not right about this pattern, because all these points are coming at the edge if you look at the pattern deviation plot. And if this is a 24, this is a 24-2, if it's a 30-2 test, we could probably ignore these points. But in 24-2, we tend not to ignore the edge points. But this doesn't make sense, because this doesn't follow any known glaucoma pattern. So, but if you look at the disc in this picture, this is a little blurred, but you can see the neurodeltoid rim is pretty good. There's no loss of nerve fibers, and there's no notching or any abnormality in the neurodeltoid rim or the neural tissue. So that means this doesn't correlate with this. So this is probably an artifact, and these artifacts we usually tend to get when we don't put the refractive correction of the frame in a proper position. So this is again.
Sir, if you could wind up, please.
Patients, yeah.
Thank you.
So, and sometimes you get visual fields which look very abnormal, and you can look at this there's a lot of dark areas, but this is, in the grayscale here, shows a very typical of a pattern. This is called like a clover leaf kind of pattern, and this is usually seen in patients who are functional or who can't do visual fields. Again, go back to the visual field. So if the disc picture and the disc is actually normal. So if you have a field defect which is grossly there, but it doesn't make sense when you look at the fundus picture, then again you know this is not the diagnosis. Similarly, you have to look for other reasons. You may have a neurological problem or some other issue which could account for a visual field defects. So all visual field defects may not be glaucomatous, so that you have to be. So visual field analysis remains the cornerstone of glaucoma diagnosis and management. It must be correlated with optic disc changes to say that this is glaucomatous, and beware of the artifacts. Thank you very much.